This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today with my longtime friend, Bob Wachter, the chairman of the Department of Medicine at University of California, San Francisco, and the author of a new book, A Giant Leap: How AI is Transforming Healthcare and What That Means for Our Future. Now, I'll be honest, I do have moments where I get a little tired of reading about AI, but Bob, I thought your new book is terrific. I learned a lot, and I would even say that, like is true of all of your writing, it's fun to read. The insights are great, but frankly, one of the things that was most intriguing is that it's kind of a conversion story. You've gone from a skeptic to an enthusiast. Now, given our time, I want to assume that most of our audience knows who you are, knows that you were core creator of the concept of hospitalist medicine and have written such great stuff on safety and COVID and so many other topics. So let's just plunge in and start with this simple question. Bob, are you excited about AI in medicine?
Well, first of all, Tom, thanks for having me, and it's a joy to talk to you. Yes, I am, and I'm partly excited because the technology really is remarkable, and I'm partly excited because the healthcare system is so broken that I think this is our greatest hope for fixing what ails us. And it's really that confluence of a technology that can do things that really were beyond my wildest dreams 5 years ago, and a healthcare system whose go-to response to unmet needs is to hire more humans. But that response is no longer feasible, both because we can't afford it and because we can't find enough humans. It's really the push and the pull that make this a really remarkable moment, and one I'm very optimistic about. And I have to give the caveat, I'm worried as hell about AI in the rest of our lives. I'm worried about bioterrorism. I'm worried about climate. I'm worried about, will anybody have jobs? So when I say I'm probably an 8 on a scale of 1 to 10, it's really a very healthcare specific answer.
Okay, now, Bob, I know that academic leaders like you are supposed to be perfect and you're never supposed to be wrong.
When
But
did that start? Okay.
but is this a case of you changing your mind?
No. When I wrote a book 10 years ago called The Digital Doctor, and it was really my effort to understand what had gone wrong in our path to digital nirvana. I've been studying patient safety for 20 years, and when you looked at handwriting errors and the kind of crazy stuff that we used to do, it just seemed like computers would fix everything. And I was flabbergasted when the electronic health record became a thing and every hospital and every doctor's office had one, and to hear from doctors and nurses and patients about how they hated their electronic health record. And I was like, how did that happen? I love my iPhone. I like my computer. How did that happen? And so that book was my effort to try to understand what had gone off the rails, why. And a lot of it was stuff that none of us had anticipated, that doctors weren't going to be making eye contact with their patients because they were busy typing. Or when patients had a patient portal, all of a sudden doctors started getting 100 emails from patients a day to try to deal with problems that should have been dealable in other ways. An observation I made was really about the sociology. You remember the day when we used to go down the radiology department every day and chat with the radiologists. And why did we do it? Partly because we went to see our film. When I tell our house staff that there used to be these things called films and light boxes, they look at me like I have 3 heads. So I wrote that book because I was so disappointed with electronic health records. And the book is a really grumpy book. It was, how did this go off the rails? And there's one chapter in the end, I think it's chapter 27, that's a very optimistic chapter because it really is, here's what went wrong and here's how and why we're going to fix this. I had people come up to me and said, who was your ghostwriter for that chapter? Because that one's like sunny and optimistic. And I said, no, I actually can see how this will get us to the place we want to get to. But we're going to need better tools. We're going to need something that moves us from what the EHR did, which is we're spending all of our time entering data and getting no useful intelligence out of it, other than it pinging us when we're about to prescribe a drug that the patient's allergic to. But you think about the limited amount of decision support, the limited tools that patients could use, even to do simple things like scheduling. So that chapter at the end was, I think this is going to work. I think we're going to get there. but I think we're going to need new tools and, in some ways, kind of rethinking the organization of healthcare. And the reason, so I don't think it was a total conversion. I could see this coming at some point. It was disappointing for the next 7 or 8 years because it still wasn't coming. But I think that the minute I used ChatGPT for the first time on November 30th, 2022, a little light bulb went off and I said, this is it. This is the kind of tool that allows us to have inputs in plain English. In some ways, curbside consults. Think about, when I'm on the wards, I was just on the wards the last 10 days. Normally, I'd be like walking around the hospital trying to find my favorite ID doctor or cardiologist and say, can I run this case by you? About 10 or 15 times a day now, I do that with open evidence or with GPT or other AI tools. So I think the tools have gotten substantially better and they are answering the problem with the EHR, which was the EHR just became a data repository, but not something that provided useful information and intelligence and insights and actionable intelligence to doctors, nurses, and patients. And it also did not solve, the EHR did not solve the problem of administrative bloat and all of the work that we have to do to move data around. Whereas I think AI will actually solve that problem. And even today, it's beginning to solve that problem, even in places like mine and places like yours.
Well, I actually took down my copy of Digital Doctor from my bookshelf in preparation for our conversation and went through it. And yeah, it is a little grumpy, but I actually thought it wasn't really negative. And it was optimistic. I think I've learned that it is possible to be optimistic and grumpy at the same time.
It's tricky to get those to balance those two things well, but I think you're right. It was optimistic because I could see how this was going to work out. It was grumpy because it was not working out at the time. And I'd say the defining theme that I took away from that book was reading about the productivity paradox of information technology, a term coined by Stanford economist Eric Brynjolfsson now 25 years ago, 30 years ago. And Eric wrote that in the history of what are known as general purpose technologies, these are things that change everything. That's electricity, the computer, the internet. The hype is wild. It looks like it's going to be just fantastic on day one. We're going to see massive improvements in quality and productivity. Everybody's going to love it. And that never happens. And the reason it never happens is two things. One is the technology is not very good in version 1.0. And so you need iteration and improvements, and that takes some time. But the more important factor, which I hadn't really thought about until I read Eric's work, was that systems need to evolve. Systems invariably take this new technology and plunk it down in their old organizational structure, their old org chart, their old culture, their old training programs, their incentives. And lo and behold, it does not deliver the promised gain. So part of the reason it takes technologies like electricity or the car or computers 5 or 10 years to deliver on the promised benefits is the systems have to evolve. Sometimes leaders need to move on, and new leaders who weren't schooled in the old ways and aren't stuck need to come in. And I think that is what I took away, that it was naive to believe that electronic health records we'd all put in Epic or Cerner, and tomorrow we would achieve a remaking of the healthcare system to deliver on quality, safety, patient experience, or cost. I think what we're seeing is it's going to take 10, 15 years, and I think we're already 10 years into it. So I think this is going to happen over the next 5 years. And it was going to take sort of rethinking of the way we organize our work, but also a new technology that delivers on the promise. I think I naively believed the EHR would do it, not realizing that the EHR really is a big filing cabinet. What it did, it was absolutely foundational because if we didn't have our data in digital form, nothing happens. But once you have your data in digital form, you need to rethink the way we organize the work, and you need tools that allow you to take that data in pretty simple ways that don't require everybody to know advanced computer coding, and allow you then to deliver to doctors, patients, nurses, hospital administrators, and others the kinds of information they need, and tools, in some ways, sometimes agentic tools that will actually do the things for them, that cut through all of the obstacles that we have today to deliver high value care. So I think that's the moment that we find ourselves in. And to me, it's incredibly exciting. I think the other thing that's really quite important is, as you know, AI, we tried AI in healthcare about 40 years ago, and it flamed out completely, leading to what's sometimes called the AI winter. And that was partly because the tools were very immature, because we didn't have our data in computerized form, but also because folks at the time started on the hardest problem. They decided to tackle diagnosis as the first thing. That's a real error. I think what you want to do, you need to build trust in these tools. And to build trust in these tools, you need to have early wins. So the fact that at UCSF today, all 5,000 of our doctors have access to an AI scribe, and most of them are using it and most of them love it, is really important, because you're talking about a pretty feasible, it takes relatively little training. And 10 minutes after you're using it, you say, wow, I can now like look my patient in the eye again. I haven't done that for 10 years. This is great. And patients notice it. Those are the kinds of quick wins. I now have a tool. I was just on the wards, and there's a little button I can push on Epic that will summarize the patient's old chart for me. 1 out of 5 patient charts is longer than Moby Dick. So that's pretty great. So those are the sort of early wins you need before you really then begin to tackle the hard stuff, like diagnosis and treatment recommendations.
Well, what's your current take on the problems that we talked about a few years ago, show-stopping barriers like hallucinations and patients' basic yearnings for empathy that only humans can provide?
I'd say, first of all, hallucinations got a lot of press because they're vivid, they're caricaturizable. We all heard the story about Google's Gemini showing you the founding fathers as being African American, or recommending that you use glue on pizza to keep the cheese from sliding off. Now, to their credit, they did say non-toxic glue, but these were sort of vivid, they were funny, they made great memes. They mostly don't happen anymore. And Ethan Mollick, who is Professor Warden, who writes, I think, more smartly about AI in general than anybody, one of his key tenets about AI is the AI you're using today is the worst AI you'll ever use. So if you played with GPT in 2022 and saw it hallucinate and said, this will never be ready for prime time in a high stakes field like medicine, you should go back and try the current tools. It's not like they're perfect, but neither am I. And I use the Biden quote in my book, don't compare me to the almighty, compare me to the alternative. They don't hallucinate very much. If you use tools, whether it's GPT or Gemini or Claude, or more healthcare specific tools like Open Evidence, they are pretty darn good. And, they're smarter than I am. Now, I still think that you need to have doctors, and I think you will need to have doctors for, at least as far as I can see, for a whole lot of reasons, a lot of them having to do with coordination and the complexities of just delivering healthcare. But in terms of getting an answer to what's going on here, they are pretty good. In terms of empathy, as you well know, Tom, I mean, there are now studies blinded studies where patients or mock patients put in answers and got answers back from either a real live doctor or a modern AI tool, and often rate the empathy better coming from AI than coming from the doctors. Now, part of those studies are unfair because the AI has infinite amounts of time and the doctors don't, but that is true. I mean, the AI does have infinite amounts of time. Now, does the AI have empathy? Of course not, but it's a hell of an actor. And I still, if I have cancer, I want a human to tell me that. If I have new kidney failure, I want a human to tell me that. But I think for many people, the AI will be good enough, and its ability to fake empathy will be good enough. And we're seeing kind of with the mental health chatbots, they are not perfect. Periodically, they do things, particularly with some of these cases with teenagers, are really egregious and beg for some level of regulation. On the other hand, try to find a psychiatrist in San Francisco or Boston, and try to find one who costs less than $400 an hour. These tools may be imperfect, but they may be good enough to solve a whole lot of problems. Try to find a primary care doctor in many places. So, they're not perfect, but they're getting better fast. And whenever anybody says, well, I can never trust a technology in something that's life and death like medicine, I have to tell you, I get into a Waymo in San Francisco about once a week, And if you want to see life and death, try making a left turn on Divisadero Street in San Francisco during rush hour. And I completely trust it. And that is empirically a reasonable thing to do because there's no question from the data that it is safer than if I get into an Uber that has a human driver. So I think the tools are getting better. And I think these obstacles like hallucinations and even empathy are things that the AI is already overcoming.
Let me ask you something about dissemination of innovation. Um, with AI scribes, I mean, I am completely in the same place as you. By the time I used it on my second patient, and it was January 15th, 2025, when I finally got to do it. With my second patient, I knew it was something fantastic and I loved it. And I realized that a weight was being lifted from my shoulders that I had not even known was there. And
Mhm.
that weight was worrying about forgetting things. Now, I loved it immediately, which makes it really painful when I meet about a third of my colleagues, I think, who are in the late adopter or laggard mode with this fantastic technology. You indicated that most of the doctors at UCSF are using it, but not all. What are you saying to the ones who have not adopted yet?
Uh, I think it's important not to push people too hard on this. I mean, people are going to make rational choices in their own world about how to do their jobs. And, that kind of early adopter versus late adopter curve is true in any new technology. If you think about the speed of adoption here, I mean, the speed with which open evidence became our go-to tool for the residents was like overnight. It was staggering and reminded me of what happened with UpToDate 25 years ago. Um, you're going to see an adoption curve, but the fact that this technology has been available at your place for a year and 30 or 40% of people aren't using it, that's amazing. I mean, that adoption curve is faster than almost anything we've ever seen. And I'm guessing the laggards will either retire or more likely will see their colleagues using it and talking glowingly about how it transformed their lives and saves them 5 minutes a visit, and they can finally make eye contact with their patient. And now I'm using a chart summarization tool so I can actually go through a 200-page chart and I'm finding it's really useful. And now, a year or two from now, or I'm using a tool to help me with diagnosis, or I have a tool in my EHR that tees up my orders and it makes my life better. Eventually, even the laggards begin to see that the advantages that the others are seeing in the use of these tools, and I think will come on board. Whether it's 100% or not, who knows? But it doesn't need to be. I think it's already hitting. I think AI scribes are already hitting a tipping point where even the people that didn't want to be first in, which I completely understand. I mean, you're doing something that's high stakes, and you've been doing it a certain way for 30 years. Even the people who are waiting, I think you're going to begin seeing them adopt it. And I think it's important if you push on them to do it too hard, I think sometimes you generate antibodies. I think it's better that the adoption sort of move organically, and I'm pretty sure it will.
Well, now I know that you're increasingly impressed by what AI can do and what it might soon be able to do. What are you saying to clinicians who are wondering what can we do as human beings that will never be replaced?
As I said, I was just in the wards the last 10 days as an attending, and I am an avid user, and I've tried hard to kind of push the edges of what I'm using it for scribes, for chart summarization, for helping me with a diagnosis. I mean, I'll sit there on rounds with my house staff, and we'll get a patient, a patient with hereditary hemorrhagic telangiectasias who had a high lactate and didn't appear to be sepsis. Do I have any idea whether HHT can cause a high lactate in the absence of sepsis? Of course not. So I pulled out my phone and asked the AI that question, and it gave me a very credible answer. So that said, I tried to envision, and I did this in the book, like what percentage of my work could be replaced by AI? And I think the answer is 5 to 10%. And even 5 years from now, if it gets better at about the same trajectory it's getting better, maybe it's 20 or 25%, which if that's true is an awesome boon to medicine. If you think about, taking 10 or 15, 20% of the labor costs out, you are delivering a lot of value. Theoretically, we'll be able to cut the cost of healthcare and deliver more care to more people and provide better access, but you still need a doctor. And I think that for most of medicine and actually nursing as well, the unmet needs are so vast. And our go-to response, as I said, is to hire more humans, more NPs, more PAs, more billing clerks, more care coordinators, more people in the call center. I think you're going to see that doctors are not going to lose their jobs. We still have plenty of radiologists. Here in San Francisco, we're all driving in Waymos, but we can't hire enough radiologists. I think that for the next 10, 15, 20 years, I think most healthcare jobs are safe. But I think that doctors who are not using these tools are going to increasingly fall behind. They're going to be too slow. They're not going to be as smart and making as good decisions as they could be if they were using these tools. But I think the unmet needs are so vast, and the needs of coordination, dealing with sort of revolving teams of people and dealing with social issues with patients. Um, I really think there are going to be, I don't think you're going to see unemployed doctors. Even in the areas where uh, when I think about primary care and the crisis in primary care, as you and I have discussed, I think there's a fair amount of primary care that could be handled by AI. Do you really need to see an internist, a general internist or a family practitioner for management of your blood pressure or get your vaccines or get your cholesterol managed? I'm guessing not. So, but do you need to see a general internist if you have 7 different chronic medical problems and are on 10 meds and also having a hard time making it home? I think so. And so I do think we're going to see a world where more of the care can be delivered with AI, probably with a physician looking over its shoulder for a while. But I still think there's going to be a need for doctors. And where people ask me, would you tell your kid to go into medicine? I'd say absolutely, in part because I do think the job of being a doctor is going to be better, more interesting, less bureaucratic, less paperwork. And in part because if doctors go, it means that lawyers and consultants and writers and journalists, they're already gone. We're probably the last field that's going to be compromised in terms of can you get a job?
So wrapping up, I know you've talked about complementary innovation. There's going to be tech innovation, but you've talked about the other type of innovation we need to do. Uh, tell us what we need to do to realize the promise that you write about in your new book.
Well, I think there's a lot of things. First of all, I think a lot of this is on the incumbents, and the incumbents being, docs and nurses and others, to not instinctively fight against these tools, but to really ask the question, we're trying to deliver the best, safest, most satisfying, most accessible, most equitable care at the lowest cost. How do I do that? And the idea that we're not going to use the technologies that will help us do that. I mean, we have a long history in medicine of doing that. We picked up the stethoscope and then the echocardiogram and the ultrasound and then POCUS and the PET scanner. And, we're used to using technologies to allow us to deliver better care to patients. And I think this is just a new and different kind of technology. So some of it is getting the buy-in, teaching people not to be scared of it. But as I say, not pushing too hard and generating sort of pushback. Part of the reason I'm enthusiastic about this now is I think that over the last 10 or 15 years, we've sort of learned some lessons within our systems about how to oversee technology. We're less likely to fall for a hype, for a fantastic PowerPoint presentation with no data. We understand there needs to be a governance structure that thinks hard about privacy and security, but if you have one that is spring-loaded to say no to every innovation because of privacy or security or hacking concerns, you're not going to get anywhere, and you're ultimately going to fail in your mission of delivering high-value care. So I think part of this is developing internal governance that is appropriately balanced in terms of being, conservative enough, but not so conservative that you veto everything that might be an innovation that would improve patient care. We need to figure out a way of measuring whether these tools are delivering on what we hope they would deliver on, and not just on day one, but on day 365, because the tools change and the patient populations change and the guidance, the rules, and the guidelines change. So those are things we need to work on, but I think we're further ahead than we were 10 years ago because some of the governance structure we'd already developed for some of the earlier tools that we were already using. But at UCSF now, we have a chief health AI officer. That's a job we didn't know we needed 2 years ago. And I think big systems are going to need people who really understand the AI portion of this. at a level above health systems, we clearly need some sort of regulatory structure. You know, when you hear some of these cases of some of the chatbots and advice that they gave teenagers, that can't be allowed. And particularly as we have more patient-facing I think there is going to need to be some protection. There can't just be buyer beware. But like in the health system, I think we've got to be careful about over-regulating this. The CEO of the Mayo Clinic said to me, I think the risk of going too slow is higher than the risk of going too fast. And I think for the time being, I hope that we don't shackle this with too many regulations. I'd say another reason I'm hopeful is I deal with a lot of AI companies and investors, and they are much smarter and much less naive about healthcare than they were 10 years ago. 10 years ago, you had these people come in and look what I did in real estate and look what I did with, making a restaurant reservation. I'm going to fix healthcare. That was ridiculous. Healthcare is incredibly complicated. The stakes are high. The regulatory environment is difficult. And the people I deal with in the Bay Area in the AI world are pretty smart about it. They have clinicians involved in the development of their tools. I think all of those things are better than they were 10 years ago, and that's partially why I'm pretty hopeful that this is going to lead us to a much, much better place.
Well, your book gave me tremendous confidence. I'm not used to recommending books that I did not write myself, but I'll make an exception in this case. I really do think this is an extraordinary book, and I highly recommend it. So thanks so much, Bob, for doing all this work, for writing this book, and for talking with us today. And I hope we can check in with you as this fantastic story unfolds.
Thank you, Tom. And coming from you, that means a ton. You're a spectacular writer and thinker, so I really appreciate it.